Notice that we're transitioning to a certain stage where we're going to be talking specifically about pediatric pathology. So as I give you guys key indicators, key presentations, age groups, things of that nature, focus in on them, okay? I took a lot of time, again, editing the slides, highlighting some things, making sure you guys are able to differentiate certain pathologies. So pay attention to that, okay? All right. Lichen syndrome, PCL, what? Shin splints, bipartite patella, and DDH of the hip. DDH of the hip specifically is more so when we start saying, okay, now we're almost primarily into pediatrics, okay? All right, so moving into plica syndrome. Plica, so you guys know that you have a synovium of the knee, okay, and these are knee folds, okay? So these plica specifically are those folds in that synovium. Those are normal, okay? So when they're symptomatic, then we call it plica syndrome. Specifically, we're talking about medial plica syndrome. I don't even mention lateral plica. I don't mention any other plicas because the one I want you guys to focus on is on medial plica. Okay? It extends from the medial joint capsule to the medial anterior fat pad. So when you ask your patient to point to where their pain is it going to be joint line necessarily? No, it'll be more of that synovium region, but it may be very vague as well. So again, this goes into your differential for medial sided knee pain. Okay? Good to go? Any questions about that picture up there? So again, it's a fold of the synovium. That's the plica. Okay? Usually they're asymptomatic. Ma'am? Anteromedial? Yes. So it's more anteromedial. Her question was, so you're saying more anteromedial versus medial joint line. Makes sense? So if they point specifically to their joint line, right, and they have tenderness at the joint line, then your differential is different. If you're pointing more towards that anteromedial, and specifically if you look there, you see how it's kind of medial to the patella? Okay, so that's that sweet spot. Okay, so again, be smart. Ask your patient, pointing with one finger where it hurts. Okay, makes sense? And then when you do your McMurray's, if they have joint line tenderness and they have that clicking and painful clicking, then you're shifting more towards medial meniscus. Did that answer your question? Okay, that's a really good question actually. But it was on the next slide, so you're too excited. Okay, so sometimes they'll describe like a snapping or popping sensation. Again, they'll specifically say it's right there in the anteromedial aspect. Okay, so focus in on that. See how it's red there? That means there's something present there. It's angry. Okay, it's an inflammation of the synovium. Again, normally asymptomatic. Okay, they'll have tenderness to palpation there at the medial to the patella, and they'll have that pop when extending the knee. What's the degrees on the screen that I want you guys to focus on? It's in yellow. 60 degrees. Okay, remember I told you guys a certain range of motion of the knee will cause certain pathology to present itself. Or to be more exacerbated by that motion. 60 degrees is the key number. Okay? Any questions about that? No? Okay. Plica syndrome diagnostics. Usually you're going to get x-rays and they're going to be normal. Okay? You'll get that sunrise view. You'll see nothing. Is this soft tissue? 100%. So a lot of times if you treat these patients and you're just questioning, okay, is this a plica? Is it something else? Like what's going on here? You will order an MRI. You see that red arrow with a question mark? Yeah. I've literally sat in a room with a bunch of surgeons and they'd say, look, I see it. And the other guy's like, you don't see anything. Okay? And so you try to convince yourself you see something, right? So the MRI may or may not be helpful. Okay? This MRI image that I found online says that is a medial plica. Sure. Is it normal? Who knows? Okay? So we'll talk about how we figure that out here shortly. But the MRI may be normal. So the radiographs again. So imaging doesn't really help you here, right? That's the point I'm trying to make. So if you have an erosion into the femoral condyle after prolonged inflammation, right, then that is an adverse outcome that could potentially occur with this disease process. Okay? I provided that picture to you. I will not ask you to classify it. That's not the purpose of that picture. The purpose of that picture is to tell you, hey, it can get worse. Okay? So if it's progressively getting worse, do you think that leads into your referral decisions? 100%. Okay? That's what I want you guys to know, that it could lead into an erosion of the femoral condyle. Okay? Which condyle? The medial. It's on the medial side, right? Okay, good to go. So treatment-wise, you guessed wrong. High five. All right, it's 50-50, 80-20. So non-operative treatment, the mainstay, NSAIDs, WISE, activity modification. Okay, they said they have pain when they go to flex and extend the knee. So you tell them to stop doing activities that cause them to do that. Okay, makes sense? Good to go. Steroid injections, if we inject right into that plica region and they get relief from it, it's not only diagnostic, but it's therapeutic. Okay, diagnostic, again, trying to lead us towards getting to the operating room. So focus in on that as well. Okay, usually with these kind of injections, again, it's a synovium. Is it the joint? Yes, it's a joint, right? So be careful when you're doing these. Okay, use proper technique. Okay. So operative, non-operative treatment failure. So we just go in there and we look at it. Okay, and that's what I was getting at. If you look at that picture there, I provided that for you guys so you guys can focus in a little bit more. I'm not going to give you a picture and say what's number 3. That's not going to happen. But I just want you to know that this is what we do. We go and we look at it. Okay, we thought we saw something on MRI. We convinced ourselves we saw something on MRI. We made fun of each other. Okay, but then we go in there and we actually see something. Maybe not much of anything. We identify it and we do what? Arthroscopic resection. We take it away. Okay? We do what we call whittling. Okay? We use an arthroscopic instrument and shave it down. Yes, sir.
Is the synovial like a sheet or?
It's a fold in the synovium.
What is a synovium?
The synovium is, what is the synovium? It's a joint, right? So it's a synovial capsule. So it's a fold in the capsule itself. Yeah, that's an excellent question. Yes, thank you for asking. Okay, because we're refreshing some stuff we talked about before. Let's finish there. Okay, did I answer your question?
Yeah.
Okay, perfect. I want to make sure before we go forward. So adverse outcomes of treatment. So we do a bunch of stuff. Surgical stuff always comes with post-operative infection risk. Always comes with what? The chance that they're going to get a thromboembolism, DVT. And again, we tell them, say, we're going to go in there and we're going to whittle away. We're going to shave some stuff down, but you may not get 100% relief of your pain. Do we ever tell patients they're going to get 100% relief of their pain?
No.
No, never, especially with this. NSAID risk exists again, and stiffness, which is our enemy, correct? Right? So somebody gets surgery, they get immobilized, they feel like they can't move it because they had surgery. It's the opposite. We want you moving. Usually with these kind of surgeries, we put a nice little wrap on it. We don't put any kind of brace. And we tell them, you can weight bear on it as soon as you feel comfortable. Okay? Yeah, we give them crutches, but we take them away really quick. Just to get them out of the hospital because we don't want people staying. Okay? That's a joke. So, all right, so referral decisions, red flags, again, non-operative treatment failure, and again, anytime you have symptoms of instability. Just because they have plica syndrome, if they also have concomitant instability symptoms, you're going to refer them, correct? That's been a common theme in many of the pathology slides that we discussed. Questions about any of that? Okay, plica syndrome is pretty straightforward. Neoplica is the most common. It's very difficult to diagnose and nail down. We do a bunch of treatments, trying to zero in on it. You get a bunch of imaging, and you see nothing, and then you go in there and you start whittling away, and you make sure that post-operatively they recover and they get back to full motion and full active duty. Okay, good to go? So this one I'll slow down. PCL, posterior cruciate ligaments. We talk about anterior cruciate ligament. Cruciate meaning cross, right? So it's a cross, okay? So it's PCL intra-articular or extra-articular? Intra-articular, correct. Okay, so primary restraint to posterior translation of the tibia. This doesn't really have any other thing any other motion that it restricts, right? This is primarily just posterior translation. Other structures that are secondary stabilizers, 100%. But this is your primary stabilizer, okay? The tears occur with actions that force the tibia posteriorly. Again, we talked about before how when we talk about, dislocations, it's always the distal fragment or the distal segment in relation to the proximal fragment or the proximal segment. You guys will get more into that when we talk about fractures in the next block as well. But that principle applies and stays true. Less common than ACL injuries, so you're not going to see them as common, okay? But I'll tell you some stuff where you might want to zero in on. People can function with an isolated PCL injury at near normal level. Okay, so does that tell you that for isolated PCL injuries that we don't really do too many surgeries? Yes. Okay, so because they can function at a near normal level. Okay, they can get a PCL brace and move on. Okay, everybody sees this picture here. It kind of denotes where that ligament is. Okay, any questions about PCL? Moving on. So PCL, when we talk about clinical symptoms, you really, again, when you're talking about clinical symptoms, you're going to do an exam, but you really want to get a good history, okay? Because I can tell you right now, and remember I said this because you will probably see it on pants, dashboard injuries are PCL injuries, okay? Dashboard injuries are PCL injuries, okay? So there's a posterior force to the anterior knee with the knee inflection. So they're sitting down in the passenger seat, okay? Driver's seat, what have you, and their knee strikes the dashboard, and it does posterior translation of the tibia, therefore disrupting the PCL. Good to go? Some other things that can cause PCL injuries: fall into the knee with a plantar flex foot. Okay, that's when you have direct impact of the tibial tuberosity. Pure hyperflexion injuries. Can you get hyperextension injuries? Are more common for ACLs, right? This one is hyperflexion. Make sense? Hyperflexion. Don't get those two confused. But it can be also, just to confuse you, hyperextension after ACL injuries. So basically what happens is you have a forward motion and then a posterior motion. Okay? So it's kind of, do you think that usually when you have that one though, that you have multi-ligamentous injuries?
Yes.
Yes. So again, those are going to be more trauma. So see how it says here, knee dislocation? Yeah. That's not good. That means it's a more significant injury. So that principle still applies. Don't let that throw you off. I would never get that tricky on a test, okay? I'm not going to tell you like these crazy forces and then you have to think about it. It's going to be pretty straightforward. So effusion, limited range of motion within 24 hours after injury, and subsequently they're going to get that swelling, right? Are you going to be able to get a good exam on them? Not normally, okay? Not normally. But then after the swelling goes down, then they'll have those feelings of instability. And we talked about that before with ACLs, right? Initially, your exam will be limited, but then after the swelling goes down, then you'll do a better exam and you'll be able to elicit that instability. Good to go? Okay, so this is a picture I added for you. In case you're a visual person, which I know I am, okay, this is what happens. Your tibia strikes the dashboard, it's translated posteriorly, okay? And therefore there's a disruption of the PCL. Everybody sees that? Okay? And in this picture, this is an isolated PCL injury. Okay? So do you think that just because he has this injury that, again, people have 100% surgical indications? No. Okay, and we'll talk about that shortly. All right. Physical exam. Hemarthrosis, bleeding into the joint. Okay? Remember, when the ligament tears, both ends bleed. Okay? So you can get a pretty significant amount of blood into the joint itself, and therefore they have restricted motion, okay, which again leads to a limited exam, okay. Decreased range of motion, like I just said, isolated PCL, that's that posterior drawer. A lot of times you guys are taught it's an anterior drawer, and then, okay, am I also going to do a posterior drawer? I will tell you this, when I teach you anterior, posterior drawer, that's one test. You are doing anterior and posterior drawer. Okay? Because you want to assess and do a complete assessment. Now let's talk about this real quick. If the patient has a posterior drawer test, which is being demonstrated there, okay, we'll go through that in lab next week, okay? Do you think that the tibia is going to lie more posterior to the femur because of the disruption of the PCL? Pause. Yes. So what you have to do is you have to bring it forward to neutral and then push backwards. Does that make sense? Does that make sense? Okay. So again, if you have an ACL injury and a PCL injury, then you have to bring it to neutral and pull forward, right? And pull and push backwards to determine whether or not there's an ACL and PCL injury. Okay? If you don't get it yet, we'll go through it in lab. Okay? But that's an important concept because I get calls. People say, oh, he's got a positive anterior drawer or positive posterior drawer. What they didn't do is take into account that they're naturally sitting, the tibia is naturally sitting more posterior because of the PCL disruption. Does that make sense? Okay. So if you look at this here, that's what that picture is showing you. You see how you can see that the tibia looks more posteriorly translated just sitting there? Okay, looks more posteriorly translated just sitting there. So you have to bring it forwards first and then push backwards. You just don't start pushing backwards when it's sitting in this position. Does that make sense? You're basically going to reduce that subluxation, if you will, because it is a bit of a subluxation, right? It's not a dislocation, right? And you're going to then push backwards. And you're like, okay, yep. And then you're going to compare it to the contralateral side. What is this right here when it's sitting there like that in that position? What is that called? PCL sag, correct. Okay, so you note that there's a PCL sag when resting at the 90-degree position. Is it? Yeah, you bring it forward and then you push it back. Yeah, make sense? Yeah. Because just because he's sitting in that position like that, does that mean that you determined it's only a PCL injury? No. Again, you're going to do an anterior drawer with it. That's why I'm teaching you that. Okay? Does that make sense? You look at that picture and you high five yourself, you're in the ER, right? You're badass. And you say, oh, I can do it. I don't even need to examine this guy. He's got a PCL injury. But you didn't bring it forward and then pull towards you or forward, right? And push backwards again to determine whether or not they had other injuries. Yes, sir.
Do you need to provide some sort of sedation for compliance, or?
Usually with these patients, to be honest with you, they may be a little guarded, but they're actually not that painful, believe it or not. That's a good question. So he was asking if you have to provide sedation for it. Okay, if you feel like you have to because you have to do a more complete exam, say you're thinking about other ligamentous injuries, for example, good question. If you're going to provide sedation, right, conscious sedation, don't just put them out, right? You're going to wake them up eventually. So, him or her. Are you going to want to do your neurovascular checks before you do that?
Yes.
Yes. Anytime you're going to do anesthesia, right, make sure you do your neurovascular checks first. Make sense? Okay? Good question. Did I answer it?
Yes.
Okay, good. Make sure, again, you rule out other ligamentous injuries. If they have a multi-ligamentous injury and it's significant trauma involved, is that limb threatening? It's in red. It is limb threatening. Good to go? Okay. Was that too fast? I think you guys were good because we talked about ACL, so that the concept of ligamentous disruption, and we talked about tendon ruptures, right? So those concepts should be ingrained by now, hopefully. Okay? Right, when it comes to radiographs, are you going to see much? Not necessarily. But if you see what? A bony avulsion, that means that not only was the ligament disrupted, but the force was strong enough or the injury pattern caused a avulsion of bone as well. It pulled bone away. Is that a different surgery potentially?
Yes.
Yes. So again, if you see that, you're thinking, okay, this could be more of a significant PCL injury, okay? So MRIs, so if you look at that picture here, well, yeah, first of all, everybody sees this little bony fragment there, right? Everybody sees that? That's not normal, okay? There is sometimes a bony fragment right about here, okay? And right about here, right? And that will lead you to think that's a fracture. That's actually called a fabella, F-A-B-A-L-A. But that's not anywhere near where the PCL lives, is it? No, you're looking to see if there's a bony avulsion where the PCL lives. Make sense? Okay? Any questions about that? No? Okay. So then when we talk about MRIs, confirmatory tests, so if you look at this picture here, of course you see the PCL disruption, right? Everybody sees it 100%. Nobody sees it. Some people see it. Some people think they see it. But it's there. So basically what's happening is you see this black stripe here. This should go, remember I told you about the fibers going consistently, right? So they should go kind of in this direction like this, and in this direction like this, so running up and down, and in kind of a vertical position. If you look right there in the center though, I'm going to stop moving it, right there in the center right there, there's white in the middle of black. See that white area? Okay, so there's a disruption of those fibers, and it looks like it's been stretched out. Remember I told you guys about the strain sign? not really something we talk about too much with ACL, PCL injuries, but it looks like it's been stretched out, okay? After you look at about a million PCL, ACLs on a sagittal view of an MRI, you'll get it. Okay, it only takes about a million though, okay? So, and again, you're gonna evaluate for other injuries. Let's pause there for a second. I wanna make sure I do you guys service in your learning. Now, I talked to you guys when there's multi-leg injuries, they could also be posterior lateral core injuries, correct? No, that's complicated. We don't teach that here like that, okay? I just want to make sure you're aware, when you're on rotation, if somebody tells you there's a multi-leg injury, you may not have the skill set just yet to be able to do a complete assessment for ligamentous injuries, okay? Because there are other tests that we don't teach you to evaluate posterior lateral core, okay? Dial test, things like that, okay? I won't teach that to you, but I'm just telling you it exists. Okay? So again, multi-leg injuries, you're always going to call somebody, right? And then as you guys practice and you get to learning more tests and get to treating more significant pathology, that skill set will become part of your skill set. Okay? Good to go? That's why it's there. That's why it says evaluate for other injuries. Okay. So adverse outcomes of disease, obviously if it's just an isolated PCL, it could be fine, okay? But what's the artery? What's the nerve? Okay, those are at risk for compromise, okay? So does that look like more of a traumatic injury there?
Yes.
Yes, yes, and yes. Okay, that looks worse than that picture before, okay? I can guarantee this patient got some pain meds. Okay, because that knee was dislocated, for sure. Okay, that doesn't look normal, does it? No. Okay, so again, if they have instability, that could be bad for some people. Okay, and anytime we talk about any kind of injuries in the ACL, PCL, we talked about articular cartilage destruction, more advanced opportunities for osteoarthritis to set in at a younger age. So that's another adverse outcome. Okay. Good to go? Okay, treatment-wise, isolated PCL injuries, okay, you want to make sure that initially, the big thing for isolated PCL injuries is what? The same thing we talked about in ACL injuries. You want to get the swelling down. You want to get the range of motion back, right? You want to get strength back, okay? So what's the two areas that we work on? Quad and hamstrings. Okay, so when you send them to physical therapy, you're going to put in your note, hey, this patient has isolated PCL injury. I want you guys to work on infusion therapy, so decrease the swelling, return range of motion, and work on quad and, strengthening and hamstring stretching. Good to go? Okay, and again, it's going to be progressive, right? The key word being progressive. We're not going to be doing a lot of strength stuff initially. Strength is bad initially. Okay? Before I forget, functional bracing. So what is the functional bracing? That allows them to perform the normal activities of daily life, right? Get up and down, move around, go to work, okay? So functional bracing is that what I talked about before is a custom brace that's fitted for the patient specifically, and it's something that prevents posterior translation of the tibia. Good to go? So what does it basically do? It puts them into more of a neutral position. Are we okay with that? Makes sense, right? So that's functional bracing. So operative, so they go on to have recurrent instability and they're symptomatic, meaning they're actually having pain, or say that it's limiting their job, okay? Special forces, operators, etc. Laborers. Then we do what's called a PCL reconstruction. The same principles that we discussed before with ACL reconstructions apply with PCL. We talked about autografts and allografts, correct? And we talked about how, depending on their age group, we could use them or we use someone else. With the PCL specifically, a lot of times we use allograft, okay? Just because. PCL is one of those things, again, you're just trying to restore some level of stability. And we'll talk about that here in a second. with PCL injuries, a lot of times, even if you tighten them up with the reconstruction, they'll loosen up. It's just present, just something we deal with, okay? So, combined injuries, then you're gonna do a multi-ligamentous reconstruction. I don't expect you guys to get dived too deep into these surgical techniques or these surgical processes, but just understand PCL reconstruction, again, it's grafting, okay? Makes sense? It's not a repair, it's a reconstruction. Everybody understands the difference between repair and reconstruction? Okay. Repair is you take what God gave you. Reconstruction is where you take everything that's already there and replace it with something that wasn't there. Good to go? Okay. So, look at that X-ray. Does that look like maybe there was a bunch of stuff that was repaired, reconstructed, augmented, etc.? A lot, right? There's a lot going on there. Okay. So, anytime we do surgery too, there's a risk that we could do popliteal artery or tibial nerve damage. Okay? Post-op infection is always a risk. Thromboembolism, again, DVT, graft loosening. I'll go ahead and highlight again. And when it comes to PCL reconstruction surgeries, a lot of times patients feel really good afterwards, and then over time they'll loosen up. That's normal. Okay? So graft selection is a big part of the process, but again, we won't get too far into that. So that's why it says recurrent instability. Even though we feel, or you feel, on exam, when you compare to the contralateral side, they feel tighter than they were preoperatively, they just don't like it, okay? So that's what they'll tell you, it just doesn't feel right when I'm doing certain activities. Good to go? And then again, the OA, all right? So do you think this patient has a surgical history if you see this on an x-ray? Yes, all right, so if you, okay, I was waiting for a different answer. All right, so if you have somebody come to your clinic and it's the first time you're seeing them and you get an x-ray and it looks like this, are you going to send them straight back to me? No. Why wouldn't you know? What am I going to do with this guy right away, right? Because he is having chronic pain. So I just told you guys, what's the stuff you're going to see with this? You're going to see arthritis, right? You're going to see, they're going to complain of this. So do you think a little bit of physical therapy and some NSAIDs might do them some good? Yes. Everybody fell for it. Okay. So red flags, anytime you have trauma assessment basically and you determine that they have neurovascular compromise, you're going to send them right away. And again, multi-ligamentous injuries. Okay. Now you're like, well, if they have major trauma and they have multi-lig injuries, would I ever actually see them? I mean, it depends, right? So you send somebody on a deployment, you did the pre-deployment screening, you cleared them for whatever, and they come back, and all of a sudden you get them and you realize, hey, they were stabilized and they were sent home. That doesn't mean that they went straight to the surgeon, right? That's not necessarily what that means. So if they have a multi-ligamentous injury, you need to make sure you take over as a PCM to get them to that level of care. Good to go? Okay. It does happen. Shin splints. Oh, excuse me, let me stop. So when it comes to PCL ligament tears, does anybody have any questions? Just on the first slide? Okay. All right, go ahead. Only injury is PCL. When his question was very valid. When I say isolated PCL injury, I mean only the PCL was injured. Okay? So again, I feel bad about this, okay, but it's just not part of the curriculum. That I can't teach you about assessing for posterior lateral corner injuries, because if I could, then you would be like, oh, I get it. So isolated means they don't have PLC injuries, posterior lateral corner injuries. Make sense? But for the purposes of definition, isolated means only PCL injury. Okay? Good to go? Okay. See, if I never even told you about those exams, you would know. Right? I'm just telling you, you have some stuff to learn in phase 2. Shin splints. Who here has not had shin splints? Okay. I was just about to call somebody a liar. All right, so shin splints is part of normal life, okay? But what shin splints is and what it isn't is different. So shin splints, by medical terminology, is medial tibial stress syndrome, okay? So it's normal to have some level of stress at the medial tibia, okay? So it's very important to understand that when we're talking about the stress here, though, with this definition, right, it doesn't mean stress fracture. Okay, we'll talk about stress fractures. Remember I told you guys that certain conditions have spectrums? So my left hand is medial tibial stress syndrome, otherwise known as shin splints, and my right hand is stress fracture. There's a continuum. There's a spectrum there. Okay. So again, shin splints or medial tibial stress syndrome, that is more of the lesser degree. Okay. Good to go. So specifically, posterior medial aspect of the distal third of the leg. Okay. So we talk about proximal third, middle third, and distal third. I remember talking to you guys about this specifically with the clavicle. You remember that? Anybody? Bueller? So same thing with the tibia. Okay, you have proximal third, middle third, distal third. Okay, so this is the distal third. So it's right about where that little black blue stick is. You see that? Okay, that's that distal third that we're talking about. Okay, so if your patient has pain at the, closer to the joint lines, is that medial tibial stress syndrome? No, that's something else. Okay, good to go. So it can be an inflammation of the tibial periosteum. We all understand, right, that the periosteum is that lining around over and around the bone. Okay, so it could be an inflammation of that periosteum. That's all soft tissue type stuff, right? Okay. So secondary to repetitive muscle contraction. Okay. I think what you're going to see again, especially if you go work in training environments. Okay, where you're the medical officer in a training environment, is that all of a sudden people get into this periods of time where they're doing increased exercise and they have an increased activity level, and this can be a sequelae of that. Okay. So clinical symptoms wise, they're going to have a history of having prolonged walking or running. Okay, and again that increased activity level. Again, it's important to understand when we're talking about anatomy here, which muscle is it? Anybody read it? Posterior, tibialis. Okay? Tibialis posterior. Okay? So make sure you understand that. If we go back to this picture here, what people want to do is they want to associate this with anterior. Okay? It's medial tibial stress syndrome. Posterior medial. Posterior medial. Okay? So again, it's the tibialis posterior muscle. Good to go? Make sure you don't get thrown off by that, okay? Are there other syndromes that you'll learn about in the next block of instruction that is not medial, it's lateral? Yes, okay? And it'll be more ankle related, but don't let that throw you off because we're near the ankle, right?
Yes.
Distal third? Okay. I want to interrupt your study. All right, so it may demonstrate pes planus with overpronation. Okay, so pes planus is flat foot. Okay, flat foot. So again, I told you guys before, you see this in a training environment. Not only did they not run, but they got 4 feet and they bought 4 shoes. Okay, so if they have foot issues, they're also going to have pain due to that pes planus and that overpronation. I will save the overpronation and the oversupination and the oh my god nation for the next block, but I'm just telling you right now that it's important when you get people that have shin splints to not only start thinking about the alignment stuff that we talked about, but check their feet, right? You got somebody that comes in with shin splints and you don't tell them to take their shoes and socks off. Have you done a complete exam?
No.
No. Okay, you have not. Okay, so if they're limping, this is your first introduction to this concept, from me at least. They have a stress fracture until otherwise proven. And when I say limp, I mean they are hurt. Okay, not just a little hobbling. They don't want to put any weight on it, and when they do, they have substantial difficulty with ambulation. Make sense? Okay. So again, if you're in a training environment, especially, you think to yourself, this might be a stress fracture. I need to put them on crutches until we get the x-rays. Good to go? Somebody crawls into your PAS and you say, oh, go get x-rays, and you're thinking stress fracture and you send them out of your clinic not on crutches, there's something there. Okay? You're not getting it. Okay? So physical exam wise, where are they going to have that tenderness? Posterior muscle. Right? Posterior muscle, right? Tibialis posterior. But it's also going to be at the posterior medial crest of the tibia in the middle or distal third of the leg. So why does it say middle there? Because again, it can be at that junction in between the middle and distal third. But just know, again, like I told you before, that if it's joint line, it's not shin splints. It's not neotibial stress syndrome. Does the muscle run up to the knee? Yeah, it does. Okay, so again, zero in on your exam. If you're questioning your exam, you're questioning your diagnosis, then you have them do plantar flexion, and you have them, do resisted plantar flexion, and they have pain with that, and they point right there to that middle or distal third. Okay, then you're like, okay, I think this is shin splints. This is medial tibial stress syndrome. Good to go. Everybody sees this picture here with the red angriness. Okay, again, one of them is meant to show you that there can be muscular involvement, but then if you take the muscle away and it's bone involvement, do you think we're heading more towards stress fracture and not just medial tibial stress syndrome? Yes, that's what that picture is supposed to kind of get to. Okay, all right. So now we talk about diagnostics. I will tell you this, especially if people are in a training environment or they have a history of a period of increased physical activity or stressors, okay, not like mental stress, stressors to their body, okay. You're going to get AP and lateral leg, so those are tibia and fibula views, okay. Remember the entire bone, please, and thank you, okay. Normal and MTSS. This is MTSS, right? Medial stress syndrome. That is primarily soft tissue, correct? But then you start seeing changes on there, like those arrows show. See the black arrows there and the white arrow there? Okay, black arrows there, white arrow there. That's not normal. You can actually see some evidence that there's a stress fracture there. Okay, you just understand that especially if you get the X-rays early, that up to 3 weeks, the X-rays may actually be normal, and that's what we'll talk about some advanced imaging. When I was the chief medical officer again for School of Infantry, and then when I was with NSW, if we had a concern, we would get advanced imaging. Yes, we would get X-rays, but as we'll discuss here, we would get advanced imaging 100% of the time to make sure. Okay. So these images have the stress fracture. You guys hopefully see that there. There's a bony overgrowth, is the way that I'll describe it there. And that's not normal, right? You see how the cortice there shows evidence of hypertrophy, if you will. You guys think about it in those terms. It's thickened there. Do you think the bone is thickening there in response to stress?
Yes.
Okay, that's where we get the term stress fracture. Okay. So diagnostic-wise, bone scans. The bone scan machine at Camp Pendleton and Balboa from Coronado Island ferry, right? Well, we send people there. Is that it was glowing hot. We were getting a lot of bone. We had our own appointment times for bone scans because we had to get a bone scan on everybody. We did a lot of bone scans. Okay, and what's the reason we do bone scans? Because if the X-rays are normal in the first couple of weeks, then how are you going to make sure? Well, you get a bone scan, okay, and what it's going to do is going to show increased uptake at the site of the stress fracture. I know you guys have probably already covered this before, okay. But this on the left here is the bone scan. You see that black dot right there? That's where the dye got taken up. Black dot right there, that's where the dye got taken up, okay. Then you go to the right and you say, okay, so, but can we also get an MRI? You can. And the MRI is going to show bone marrow edema and or periosteoedema. Now compare the pictures on the left to the images on the right. Okay, you see how the bone scan doesn't look that significant, right? But then you compare that same patient and you see these periosteal changes here and the bone reaction there. Okay, that's not good, right? But again, the bone scan was quick, cheap, and able to get done, especially in the training environment, because we're just so used to sending people. Okay, let's go back to bone scans. When you talk about bone scans, is there a dye that a patient gets injected with?
Yes.
Right. So that's when we talk about uptake. That's what we're talking about. That's the uptake of that. Okay. Just gotta make sure we're on the same page. Okay. Good to go? Any questions about imaging?
No.
So you're going to ask yourself, well, if you're going to get an MRI anyways, why don't you just get an MRI? Who in here has tried to get an MRI for themselves or a family member? How long does it take? Long time. But the bone scan, like I said, that thing was glowing hot, man. Right? So you can get bone scans in and out. Okay? We had a duty driver that would take people to get bone scans from the infantry training range. Okay? Right. Shin splints. Again, this is shin splints. This is medial stress syndrome. This is not a stress fracture. Okay? What's the treatment for? Pretty conservative stuff, right? All right. So one thing I will tell you is that, again, it mentions on this slide, arch support shoes. If you don't address their feet, you think they're going to keep getting shin splints?
Yes.
Even after they get out of that training environment, right, in the future, they could still have recurrent shin splints. Is that going to drive you crazy in your practice?
Yes.
Yes. So take care of their feet, okay? Compression calf sleeve, all right, so that's another thing. I provided a picture there. It's kind of funny how it blended into the slide. It looks very nice. Okay, I didn't do that on purpose, it just came out that way. But so you guys know that those compression sleeves is a multi-million-dollar industry, right? I don't have a recommendation for one. Okay, I'm just telling you, if it causes compression and it doesn't cause pain, significant pain, and they can feel their toes, that's probably a good one. Good to go? Okay, stress fracture treatment. Again, not talking about triple stress syndrome. Tibial stress syndrome, yes. Shin splints, this is talking about stress fractures. I just told you, anytime you're suspecting stress fractures, you need to get the patient off that extremity. You know, I've literally seen it where trainees come into the BAS, okay, or excuse me, come into the sports med clinic, right, and we tell them, a provider sees them, the time it takes for the patient to walk from our sports med clinic across the street to the medical clinic where the radiology tech is, then they sustain an actual fracture. Okay, so again, some people can be on that borderline of not only is it a stress fracture, but it's actually fractured. Have I lost anybody there? Remember I told you guys it's a continuum? I'm sure I lost at least one person. So it's a continuum, right? So you have stress reaction is my left hand, stress fracture is my right hand. Okay? Now the stress fracture, even in my right hand, doesn't mean they're actually fractured. Pause. Okay? Because you guys, I showed you pictures of stress fractures, right? But you didn't actually see the bone completely disrupted. Make sense? So if we go back to this picture, you guys don't like my hand analogy? So this is a stress fracture, but it's not a fracture, correct?
Yes.
There's not a complete disruption of the corticity there. There's not a tibial fracture. Make sense? If there was, then it would be a question as to whether or not there's a fracture present. Make sense? So that stress fracture terminology can be a bit of a misnomer. Just understand that just because they have a stress fracture doesn't mean they have a fracture. That's why they're able to walk on it. Make sense? So they, yes. You're not going to be able to finish? Yeah. What is that? Pathological fracture is the question, the terminology he's using. Pathologic fracture we use normally in conjunction with the C word. Okay, so don't really use it in this case. Okay, so don't use that terminology. Yeah. Okay. Yes. Yeah.
So stress fracture can be both. So it can be stress fracture.
A stress fracture can become a complete fracture.
But it can also.
It could also be what? I'm sorry.
It can also be not a fracture.
Well, stress fracture is always a stress fracture. It's just not completely fractured. Make sense? Okay, don't worry. I'll hit it again. I'll hit it again. Okay. But the point I'm trying to make with that is a lot of times you guys will get these X-rays and you'll say, oh, they look normal to me because you don't see a fracture. But the patient is limping. Okay? They have substantial limp with substantial pain and a lot of redness and swelling in a distal third of the tibia, and you don't get them off that extremity, and you go back to training, for example, you just potentially fractured somebody. Good to go? And then are they out of the fight?
Yes.
Yes. Okay. Counseling. All right. So again, treatment, period of relative rest. What does relative rest mean? It means relative to whatever the heck was causing this in the first place. If they were in a training environment, you take them out of it. If they were in some kind of corporate retreat, right, and they were doing some kind of awesomeness, wizardry with like physical activity or something like that, you take them out of it. okay? Wilderness survival training, whatever, all that corporate stuff, all that civilian stuff. Okay, cast immobilization and limited weight bearing. Cast immobilization we do use for tibial stress fractures, okay? And primarily, the reason we do it is if we put somebody in a long leg cast, right, like that picture shows there, are they able to put weight on it? No, so you slow them the heck down. So sometimes we put that kind of a cast on somebody just to get them to be compliant. Are they still going to make it nasty?
Yes.
Yeah, they're still going to try to do something, but they can't do whatever it is they were doing that caused this. Make sense? Okay? I'm not trying to teach you bad habits. I'm just telling you how we think sometimes. Okay? Sometimes you have to protect the patient from themselves. Okay? A long leg cast, do you ever, in the history of ever, put a patient in a long leg cast with a leg fully straight?
No.
No. We put it in slight flexion to, again, maintain tension. Okay? That way they don't get stiffness and shortening of those tendons. Good to go? Okay. Says there 40-degree angle, right? Okay, we'll get into casting and block forward. We'll have some fun with that, guys. Okay, the guys over from Vamps, he'll come over. My buddy Dave Smith is the OIC over there. We'll have some fun with it. Okay, we'll put people in casts. We'll leave them in casts. We'll go home. We'll see what happens. Okay. Just understand that the big thing I want you to take away from this is limited weight bearing. And again, it's 100% non-weight bearing until you figure it out. Okay? Good to go? Okay. So when do they resume activity? Well, normally for a stretch fracture, if that was what you were thinking of, it's a minimum of 6 weeks. But even at 6 weeks, we still don't tell them they can do full physical activity or resume activities until they have a full resumption of the pain level they were having. Okay, good to go? All right, so this is going to seem weird. I'll hit it and we'll move on to a break. Is when we talk about operative, you see that big nail right there that's running down the center of their tibia?
Yes.
The intermedullary canal? Okay, right there, right there. Okay, that patient didn't actually have a fracture, right? But they had a significant stress fracture that was on the precipice of fracturing, okay? So the only way we can prevent them from fracturing is to put a nail down the pipe, if you will. This is very commonly done for patients that have a significant indication for it, meaning they have a significant degree of a stress fracture. We good? Do you think if we put a nail down like that they could have some residual pain after that? Yes, because this is awesome stuff, right? So we drill an entry point and then we nail. It's a nail, right? So we hammer that thing in. Okay, so we put it in from right about up here all the way down the pipe. Okay, so again from up here down the pipe. Okay, and then we put these screws in distally to keep it from sliding up and down. Okay, so do you think the patient could have some anterior knee pain from where we nailed that thing in? It's a nail, right? So you got to have a hammer. Okay, we hammer that thing in there. We drive it home, if you will. Awesome. So what are the adverse outcomes of treatment? 100% of patients describe some level of permanent anterior knee pain. Okay, can you also drill it from the other end? Yes. Okay, let's not get into that. But I'm just telling you that they have some level of permanent anterior knee pain because of the amount of force and awesomeness that we had to use to get that thing down the pipe. Good to go? And then, as you guys' favorite, your NSAID wrists still exist. Okay? You guys love farm, right? Okay. Let's take a break, come back to the top of the hour. So, I added this. Okay? The female triad is in your book, but it wasn't originally in the curriculum. I think you need to know the female triad. Do trainees that exhibit components of the female triad also have a risk of stress fractures, an increased risk of stress fractures? They do, so you do need to know this, okay? I will not test you on this necessarily in the flight test, okay, but I do think it bears some moment to talk about because I did, in fact, find it on a pants for you question, or for me, a pannery. I don't take pants, right? Pannery, my third time, old dude. So female triad, right? Low energy availability, menstrual dysfunction, and what? Low bone mineral density. Have you guys talked about the female triad yet? Okay, I think it's like a thing you need to know in orthopedics, because if a female athlete has this syndrome, right, of this triad, it puts her at risk for all kinds of MSK injuries. So if you don't know this exists, you don't know to look for it. Okay, why did I put not ortho on there? Do I treat any of that in orthopedics?
No.
No, I'll treat the stress fracture, but then guess where they're coming back to? You. So there's the slide there that shows you that there's a physical, there's potentially psychological, and there's behavioral components to that, okay? So take a look at that. I think that'll serve you well when as you prepare for the pants, okay? So, not ortho, okay? But if patients have symptoms greater than 3 weeks despite conservative care, then you'll see us send to ortho too, okay? I just wanted to make sure you understood that I'm not going to test you on this, but I do think you need to know this. Any questions about something I'm not going to test you on? Of course not. So bipartite patella, okay? And you're welcome, by the way. So bipartite patella, so bipartite, 2 parts. Well, that makes sense. There's no special language there, right? But bipartite patella. So I guarantee that you're going to, as you travel throughout the military and the rest of your medical career, you will run across somebody who will diagnose somebody with a fracture that has a bipartite patella. But it won't be you, because you're going to remember this lecture, okay? So it's a failure of the ossification centers to fuse. So basically those open growth plates of the patella, because you would agree that when a baby is born, right, that as they grow, the bones have to be able to expand, correct? Then once the growing is done, then they don't need to expand anymore, they don't need to go up or sideways, and therefore those areas will fuse, okay, they'll close. That's why we talk about closed growth plates. So this is a failure of that growth plate to close. That's another way of saying it, okay? So where are they going to have pain? Well, if it's that area there, then that's described as a superior lateral corner of the patella. That's the most common. Can it be somewhere else? Sure. But that's the most common, okay? Any questions about that? And what's going to happen is a patient's going to complain about knee pain, right? And then when you say, where does it hurt? Are they going to circle the patella?
Yes.
Yeah, that's what they all do, okay? Now, if you're really trying to say, well, where in that circle, good luck. But I'm just telling you, for some reason, it's pinpoint pain in the superior lateral corner on a PENS test question, then that's the answer, okay? So, again, on physical exam, that's where we're going to hurt. This is where that term synchondrosis occurs, okay? That's what that means. Okay, that's that inflammation and that pain specifically to that region, okay? So if you guys haven't heard that terminology yet. You guys remember when we talked about enthesophytes versus osteophytes? So an enthesophyte, is that in a joint?
Yes.
No.
No.
That's an osteophyte. 50-50 chance. Okay? All right, so that's an osteophyte. So don't use the term enthesophyte when you're describing loss, L-O-S-S. First of all, it doesn't go in those letters, right? But second of all, it doesn't even make any sense. It's not intra-articular. So is this intra-articular or extra-articular? Extra-articular, correct. Good to go. All right, I had to pick on somebody. Not having too much fun today. All right, so diagnostics. Okay, someone's gonna get this X-ray, not in this classroom, right? Please. All right, and they're gonna say, oh, patient has a fracture. Okay, nope, it's not a fracture. It's in red. It's not a fracture. Okay, if you look there, okay, and I don't know if I can ever convince anybody of this that's here in IPAP, but if you look at this, the margins of this bipartite patella, you look at those margins, it looks like a perfectly fitting puzzle piece. Those edges are smooth and round, okay? If they're jagged or indistinct, then it might be a fracture. Do fractures fracture perfectly smooth?
No.
No, they don't, okay? So, again, I don't know if I can ever convince anybody of this here, but if you look at that and say, okay, there, it looks like smooth edges, so this looks like it's more of a bipartite patella, okay, 2 pieces, okay? So, if a patient presents with a history of trauma, though, do you think it might be a fracture? Yes, so take that as something that's clinically valuable then, when you're talking about physical exams and diagnostics, okay? If they have a history of trauma, they took a blow to the kneecap, or they had a fall into bent knee, and then you see something you suspect could be a fracture, then it might be real. See how I put that together as well? So read the scenario, read the question. Good to go? Okay, adverse outcomes disease. Well, it's not a fracture, okay? So, but it's causing pain. That's why they presented initially. So it can cause chronic pain, therefore, okay? Quadricep dysfunction. Okay? If somebody doesn't want to do certain activity and they let their quads weaken, that can cause quad dysfunction, right? That's what we're talking about. So, and patellar maltracking, okay? So, you guys love patellar maltracking, right? That's something that was so clear to you, okay? But I'm just telling you that just because you see that the patient has tenderness of palpation about the superior lateral quarter, and you have an x-ray that shows what you diagnose as a bipartite patella because there's no history of trauma, doesn't mean that you don't need to do a full assessment of the patella and assess them as they flex and extend their knee and see if they have a J sign. Did you guys look at that video yesterday? Of course you did. Okay. Well, somebody was honest. All right. That's refreshing. All right, so treatment-wise, so it doesn't sound like a big deal, right? So initially, it may not be. So you put them into conservative care, NSAIDs, rice, continuing modification, physical therapy. Operative, if it bothers them enough, do you think, let's go back to this view here so it makes more sense. Is that a significant portion of the patella?
Yeah.
No, it's not. Okay, because the tendons insert right about there, okay, and right about there. So superior full and inferior full patella. So if you were to take a small piece of it away, would it significantly impact their ability to extend and flex the knee? Not necessarily. Okay, make sense? Okay. You're trying to convince yourself that I'm wrong. I'm just telling you. That's why this slide says surgical fragment excision. You just literally go in there and you take out the puzzle piece, and the patients do fine. Okay. Sometimes when we go in there and we start whacking things, okay, if we notice that there may be a potential for instability or weakness, we can augment. We can put anchors in there to augment tissue, okay, and make sure they have more strength. So we take that into account. Don't worry, we don't just go start taking puzzle pieces out. Okay. Internal fixation, so that's reserved for, you don't want to take it out because you feel like it's going to destabilize that extensor mechanism, right? That's what we're talking about. So then you fire two screws to basically anchor it down to the other piece. So do you guys, when you guys hang a picture on the wall, do you hang the wall to the picture or the picture to the wall? Wall to the picture? Okay. Okay, so you hang the picture to the wall. So therefore you drive the nails in that direction. Everybody sees where the heads and the nails are? Okay. Or screws, I should say. We can use nails too, but screws. So lateral retinacular release, that's a little more confusing. We don't really do those anymore. Okay, those we found that they aren't good. But the lateral retinaculum, so we remember when we talked about the MPFL yesterday, and we talked about how that provides restraint to the lateral translation of the patella. Well, it's a lateral retinaculum. Everybody take your hand, put it on your thigh, on the lateral aspect, work your way down to your knee, and understand, okay, this is what I'm talking about. If those areas are tight, okay, do I need to back up? Can you tip it? Yeah, right there. And so it got through. So if that's tight in that area, it can pull, right? So if you release that, you release that pull. Make sense? So that's what we're talking about. It's releasing that lateral area, that lateral retinaculum. Okay? And maybe that decreases that pain. Because the most common area is the superior lateral aspect of the patella. Are we good so far? You're not releasing the entire IT band, just to be clear. Okay, you're not releasing the entire tensor fasciae lata. It's just that retinaculum. It's a very specific structure. Okay, good to go? Okay. Risks, well, we did surgery, so of course surgeons like to cause infection, right? Nope. But there's a risk of infection, and we counsel all patients on that, okay? Chronic pain despite treatment. Even if we go in there and we hang the picture on the wall, right? Not like someone else wanted to do over here, we never do that, okay? Then they could still have pain. So do we tell patients they're going to be pain-free after surgery? No. And if you tell the patient you're going to come to us and you're going to be pain-free, I'll find you, okay? So, but again, your scary stuff is if you go and you say, well, I think I have a body part type to tell it's symptomatic, but, oh, by the way, you also have instability and or weakness. That's not good, right? You've hit that so many times now. That's why it's important to be thorough in your exam. Don't just say, where does it hurt? Go, ooh, does it hurt when I push there? And that's it. That's your exam. All right, make sure you do a full exam. Good to go? Okay. DDH, developmental dysplasia of the hip. We're definitely in some pediatric zones now. Okay? All right? So DDH, you need to know this. You will see this again, not just on the 17th, okay? But on Vance. They love DDH and they love skipping, okay? They love those pediatric specific conditions. So I took a lot of time doing what you see here, breaking it down for you, okay? Am I going to go down the rabbit hole of all these different pathologies? No, this is orthopedics. But make sure you understand how things contribute and things relate. Okay, does that make sense? So developmental dysplasia of the hip. When we talk about developmental, is it intrauterine or is it intrauterine? Yes. Okay, so stay with that. So it's as they were developing in the womb. Make sense? So they come off the chute like that. All right? Is that on video? Yes. All right, so but it's abnormal formation of the femoral head or acetabulum. So DDH is something that you need to catch early on, okay? So when we talk about risk factors, it's family history, female, and what? Breech presentation should also be in yellow, I apologize. Okay, breech presentation, sorry. I missed that one. But family history, female, and breech. Family history, female, and breech. Pants question. Female patient, some kind of complicated delivery, and there's a family history of DDH. Does the patient have DDH? Probably. Okay, read the answers, but that's what Pants loves to ask. Okay. Packaging disorders. So as they're molding in the womb, these other things can occur. Is CNT on there? It is. We covered that. Okay. So again, understand as you guys have been progressing through this IPAP experience that things don't occur in isolation when it comes to these kind of disorders. Okay. They often come together. We're not going to talk about metatarsus adductus. All right. We're definitely not going to talk about hyperextension dislocation of the knee. But metatarsus adductus, you guys are going to talk about in the next block, because metatarsus adductus is at the feet. Yes, that's the feet. So that's the next block. Okay. So don't worry, you'll get your fill. Okay. So dysplastic hip can also be seen in other neuromuscular conditions. So dysplastic hip, usually when we talk about dysplastic hip, we tend to use that more in older patients, but it's fair game here too, because it's still dysplasia, right? But remember how we talk about Osgood-Schlatter disease and how in adults, if you see that those radiographic findings, it's not Osgood-Schlatter disease, it's patellotendinitis. The same thing with this. Just because they have a history of DDH, right, and they're treated successfully, as they go on into adulthood, is it important to know that they have a history of DDH? Yes, because could they be predisposed to femoral acetabular impingement? Yes. You see how it all comes together, right? It puts them at a risk. Because it's abnormal formation of what? The femoral head and the acetabulum. Good to go? Okay. So when we talk about types of developmental dysplasia of the hip, so this picture I think is pretty decent. So it shows you normal. So it's a normal concentric relation of the femoral head to the acetabulum. So the ball sits in the cup as it normally should. Okay? Now there are degrees of development of DDH. Okay, so you could have a subluxation. You see where the head is kind of perched on this acetabulum here, but not all the way out, right? Still not all the way out, okay? And again, it's perched here, but it's not all the way out. okay? But as you move over here, you see how it's out now, right? But it's not completely out. So that's called a low dislocation. So again, here, it's out, but not completely out. So it's a low dislocation. And then over here, that's pretty dull, right? That's out. That's a high dislocation, okay? So am I going to test you on that? No. I just want you to understand these principles, because when I talk to you about special tests in about, I don't know, a minute and a half, I want you to understand that when you're doing your special tests to evaluate infants, for DDH, there's a range of looseness that could exist. They're not all the way in or all the way out sometimes. Are we good with that? Okay. I'm not going to ask you specifically to state it, okay, guys? Don't lose sleep. All right? I don't want you to disrupt your neuro study. Okay. So neonates, typically, neonates are asymptomatic. Why? Because they can't tell you anything, right? Do babies cry anyways?
Yes.
Yeah, right? Not just us, babies do too, right? So infants and children though, especially if it goes unrecognized or undiagnosed, they'll have a limp. This is your first introduction to the fact that when you get a question on pants, pause for effect, and it tells you limp, keep reading. Don't just pick one of them, because usually they'll give you all the ones I'm going to talk about, and then they'll give you some component in there in the question that tells you it's definitely this one and not that one. Make sense? Okay? Limp is non-specific or sensitive for any one of these conditions I'm going to talk to you guys about. Okay? But it's present with this too. Okay? In adolescence, right? So again, not diagnosed or not appropriately treated. They can have subluxations, dislocations. You'll get x-rays and all of a sudden you see an acetatum, it just doesn't look right. Okay? That just doesn't look right. It looks like something's wrong. Okay? Or you see a femoral head, it just doesn't look right. Okay? So why do you think they have limb length discrepancy? So let's talk about this. So limb length discrepancy is because of what? Is the ball in the socket? No. So therefore, it's not out at full length. It's not in its normal anatomical relationship. Make sense? So one limb can appear shorter than the other. Good to go? Hip pain, is that specific for anything? No. Right? Good. So when we talk about, now this is the important part. So when we talk about DDH, right, developmental dysplasia of the hip, it's important that you guys know these physical exams, because they will literally describe these exams, and I will too. Okay? And I'll tell you what's positive, what's negative, but if you don't understand how the exams are done, you may not get the question right because you're guessing. Okay? Some of you guys are really good guessers though. Okay? But the two tests you want to know is Barlow's and Ortolani's. Okay? Barlow's and Ortolani's. Okay? You see at the bottom there, that didn't used to exist. That little link right there, that didn't used to exist. I'm giving you guys a video that I think will help explain that. Okay? During the lab, I will bring the bebe. Okay? I will bring a little bebe with me. Right? And if you guys want me to demonstrate those exams, I will as well. It's not part of the curriculum, but it's value added. Make sense? Okay? Can I demonstrate Ortolani or Barlow and Tippett? No, he's not a baby. Okay, so therefore it's challenging to do that. Okay, even with the mannequin I have, you guys have taken BLS, right?
Yeah.
That mannequin doesn't articulate well, so you can't put him in positions, right? So it's still kind of not the best. But I'm trying to get the mannequins, but they keep telling me, yeah, right. We can't even pay. You can't even go TDY right now. Good luck. So, but anyways, I digress. So usually when the baby's born, you guys hopefully by now, and you will know next semester for sure, in pediatrics, right, that babies have to get an initial screening eval done. It's a complete eval. A lot of words, physical exam, everything, within the first 24 hours of life. Okay? And as part of that exam, they're going to do the Ortolani and Barlow. They're going to do a hip screening to check for DDH. Okay? And then after that, you guys know this concept. Again, you haven't done peds yet, I get it. but there's a well-child check. A lot of you have children. You have to go in so often, right, to check and see if the child is meeting those milestones. Okay, so we call that ages and stages. Okay, won't get into that, but just understand. We just understand that Orlani is less palpable after 3 months. Okay, so the Orlani test is less palpable after 3 months. Okay, so before we get too far then, what is the Orlani and Barlow? Okay, I prefer to think of it as Barlow and Orlani, because Barlow lets you know what you're doing. Barlow, so think of it as BO, body odor, right? BO, so Barlow, you're trying to actually dislocate the child. Orlani, you're trying to reduce that dislocation. Okay, have I lost anybody yet? Okay, so I will jump to this and then go back. So the Barlow, you see how this abducting the hips together? So the hip is flexed to 90 and the knees are flexed to 90. They're abducting, so they're bringing the knees together and they're pushing down, pushing down and back, trying to dislocate the hip out of the acetabulum. Okay, so you're trying to actually dislocate them. Okay, then with the Ortolani here, you're reversing that motion, so you're adducting the legs. They're still in that normal that position we just talked about, and then you're trying to swoop and scoop the head of the femur back into the acetabulum. Okay, almost like a frog leg thing. Okay, so again, Barlow and Ortolani. Barlow will dislocate the patient, Ortolani will reduce the dislocation. Okay, I actually think this little picture thing is pretty good. Okay, and if nothing else, I gave you the video here. Okay, so watch that video, and if you still have questions, I'll take a few moments in the next lecture. Okay, I'm trying to get you guys out of here today. Okay, so but I just described to you what Ortolani is then. Does the Ortolani dislocate or reduce the reduce? Reduce. So after a certain amount of time, you will not be able to reduce it anymore. Do you think that's bad? Yes, that's a surgical indication. You already know that, right? Okay, so yeah, of course you do. So but that's the hip exam. And again, it's periodic. I explained those periods. Okay. Now the next component of your physical exam though is the shortened segment. Okay. We talked about this before. If the head of the femur is not in the acetabulum, can you have a leg-length discrepancy?
Yes.
That's what we're talking about. So a shortened thigh segment. Okay? So the Galeazzi sign is this picture here and here. So the infant, you're looking at it from the foot of the bed, right? And you're looking for equal height of the kneecaps, of the knees themselves. Okay? If one appears to be lower than the other, then that's a positive Galeazzi sign. And that's an indication that there's a shortened thigh segment. Good to go? Okay. Posterior skin folds. Okay. I see how I even circled it, right? So the skin folds that are circled there do not equate to the ones on the unaffected side. Okay. So that is what? That is your posterior skin folds sign, if you will. That's what we're talking about there. And then if you are, especially if the child is dislocated, do you think they're going to have decreased abduction?
Yes.
Yes, they will. Of course they will. It's on the slide. But that's something. Okay? Make sense? Okay. But that's not in itself. Not one of those things in and of themselves are as good as all those things together. Does that make sense? So that's why, again, when they do that initial baby check, in that 24 hours, there's like a checklist they can follow, right? And they have to document it. Okay? Special test video, enjoy. Okay? This is a good picture. Again, when you're studying for this test on the 16th at midnight or the 17th at 2 in the morning, okay? Just make sure you go back and look at that video one last time and understand, so you can describe it to yourself or someone else. Okay? Diagnostics-wise, this is challenging, okay? In the sense that I need you guys to know this. I need you guys to know and understand, when do I get x-rays And when can I get an ultrasound? Okay? X-rays, AP pelvis, how long do you have to wait to get the X-rays? 4 to 5 months. Okay? So does that look shortened to you there? Does that look shortened to you over there?
Yeah.
It looks short, right? Right? So do you think we get X-rays? You would say, well, we've got to wait 4 or 5 months to get an X-ray. No, we don't. Okay? We get an ultrasound. But wait, there's a complication to that. You can't get an ultrasound prior to 6 weeks. Okay? Why? What does it say there?
High false positive.
Because they're loosey-goosey, right? So they start to tighten up. Okay, that capsule starts to stiffen, right, over the first 6 weeks of life. Okay, so if you're doing an exam, do you think your exam then is very important with PDH?
Yes.
Super important, paramount. You must be able to do this exam, okay, if you're working in certain settings, right? Because you have to wait 6 weeks, or you have to wait 4 to 5 months. Right, so your exam is paramount. So will I test you on this?
Yes.
1,000 and 500,000%. 15th degree. Okay. So know these exams. Okay. So when do you get ultrasounds? Any patient you're even questioning about it. But what are the 3 risk factors I told you guys about? 3 females. What was the last one? Family history. Yes. 100% ultrasound. Okay. 100% ultrasound. Like, not, it's just, I don't know, 1,000%. Again, it's the 15th degree. I give these little pictures to you here so you can see. Okay, when you're looking here, you can see that the acetabulum, the ball, is well rested inside that groove, the cup, right? Which is what? The acetabulum, right? So if you draw a line across that horizon there, it's seated in there. If you draw this line here, it's not seated. Okay? Do you think this is operator dependent?
Yes.
Yes. So again, it's seated within that. Okay, so the line splits the 8-ball, if you will. Here it doesn't. There's a certain percentage of the 8-ball that's above that line. Everybody sees what I mean by 8-ball and above the line on this side? Okay. Do you need to know that? No, you don't. Again, this is ultrasound operator dependent?
Yes.
Yes. You could put the patient, the infant, right, in a position with a reduced, and it looks normal, right? So you have to make sure that when your techs are doing these things, that they're doing them appropriately. A lot of places that do, they're highly trained, okay? I won't go into the dynamics of ultrasound when it comes to interpretation, because there's a lot there, okay? I took that out. It's too much. I literally have to give you, again, I don't know, 80 images for you to accurately tell me whether or not the hip's located or dislocated. Make sense? That's not fair to you guys. But just understand that the ultrasound, when you get the report, you need to read what's called an alpha angle, right? And if they say it's a normal alpha angle, that means that the head of the femur, right, is well located in the acetabulum, and there's no concern for dislocation or subluxation. Make sense? Okay. All right, so adverse ocular disease, the longer it's out, right, the more difficult it's going to be to reduce. Remember I told you how things start to tighten up in that first 6 weeks? So if it's been out for a while, do you think it's going to stiffen up in the out position? Yes. So it's going to be more difficult to reduce. Okay? It can lead to premature osteoarthritis? Well, that makes sense. Can it lead to a dysplastic hip, therefore, potentially FAI in the future? Absolutely, that's what FAI is, right? So if it's unilateral, they can have leg-length discrepancies. Ipsilateral knee pain, valgus instability. We'll talk about valgus next week. Okay? Gait disturbances. If they have a shortened leg, do you think they're going to walk funny? Yeah, right? So bilateral DDH can have back problems. Right? Just think about this. If both sides are short, right, because the subluxes are dislocated, do you think from them walking like this that it's going to hurt their back? Yeah. It hurts my back just doing it right now. So, but that's for different reasons. So treatment-wise, so again, you did your physical exam. it's within that first 6 weeks, can you get an ultrasound? No. Okay, can you get x-rays? Well, let me back up. You could get them, but they're not going to be of value, correct? For the reasons we discussed, okay? So what are the things you can do though? You can modify swaddling. Okay, does everybody know what swaddling is? Okay, I will not demonstrate the swaddling with the baby. Okay, that's not this course. So basically you lay the blanket down, you lay the baby in the middle of the blanket, and you fold the blanket to make the baby burrito. Oh, I'm getting hungry. All right, so that's swaddling. So therefore, if you can take away, and do babies feel good when they're swaddled?
Yes.
They do, right? Because it simulates what they were like in the womb. Remember, I didn't just do orthopedics. I actually did pediatrics, believe it or not. So, yeah. But anyways, so you can do the swaddling of only the upper extremities though, to at least get them to be quiet so you can get some damn sleep. Okay? But that's what you're going to educate your patients on. Okay? Good to go? So upper extremity swaddling. So the goal of any treatment, you need to know this, is to achieve concentric reduction so that the normal acetabulum continues to form. Remember I told you things are growing, right? Things are forming. Okay? So therefore you want to continue to have that normal growth, that normal formation. So Pavlik harnesses in infants less than 6 months. Okay? So do you guys get the sense that if you get to about 6 months and you haven't done anything, you might have to do something surgical? Yes. So that 6 months is paramount. So the sooner the better. Okay, but the Pavlik harness is this harness down here. You see this here? How many of you guys can put this on somebody? A baby. On each other. Okay. Now, it takes a little bit of training, right? It's a little awkward. And if you put the patient in there incorrectly, do you think there's issues? We'll talk about that, okay? How long do they wear it? Full time for 6 to 12 weeks, and then followed by nighttime wear for an undetermined amount of time. Kind of like provider specific. Different pediatricians have different guidelines they cover. I won't get into that, okay? Just understand the Pavlik harness, you want to get them into it less than 6 months, and that they're going to wear it full time initially for at least 6 to 12 weeks. Good to go? So that's a rule of 6. 6 is 6. 6 plus 6 is 12. Yes, I just confirmed. Okay. So operative stuff though, if you get to that point, okay, you have to, if you're going to do a reduction, do you think the baby's going to be awake? No, they're going to be asleep. Because not only do you have to do the reduction, you have to maintain the reduction, and you have to put the baby in a cast. Good luck. It's a 3 to 4 person maneuver to do it. So, okay, so you see this down here? That's the cast. That's the cast right here. See that? So, do you think that you have to cut a hole out so that the baby can do things?
Yeah.
Yes. Do you think it gets nasty and the parents bring the kid in and we have to swap cast out sooner than we wanted to?
Yeah.
Yes. It's a pain. Okay. And then if you try that even, and you're not able to maintain that reduction because you're going to get x-rays, right? Then sometimes you have to go in there and you have to put things in there that weren't in there before to get it done. Okay? That's all you need to know. So that's an open reduction. Make sense? There you go. Do you think after we do an open reduction, we put them back into this thing? Yes. Okay. And hopefully, again, the parents will listen. So here's your adverse outcomes of treatment. I talked about the Pavlik harness. You must know those. Parents may ask you these. Okay. So, do you guys understand that here that are the hips abducted or adducted in this position? Abducted. Okay. And the knees are flexed, correct? Right? So you need to know how to put this on correctly, okay? Correctly, right? Right? Because if you don't, this happens. So when you're talking about the flexion, you're going to have the femoral nerve palsy, and when you're talking about the abduction, you're talking about osteonecrosis. Osteonecrosis is bad, right? Bone death. You don't want that. Okay? So know these two guys. Okay? So referral decisions, all positive or aligning. All positive or aligning. Meaning, if you're able to dislocate and then reduce it, that's something. But if you can constantly reduce it every time you do an alignings, that demonstrates that the patient has instability, correct? Okay? If you push hard enough, you'll dislocate that beta. Okay, because they're loose, right? But the Orlani tells you that you can do treatment for it. So therefore, you should send them to us. You guys are going to go home. So one of you guys at least is going to go home. You're going to read about Orlani suggestive and Orlani confirmed, all this stuff. If you do that, good for you. Okay? This is where that comes from. Orlani, positive Orlani is what they're talking about. So you're able to reduce it. Okay? So I don't want to go there because then we'll go into the whole other thing. Okay? But as you get, when you go into pediatrics, they may hit you with that. So just understand, there's more to it than just that. There's Orlani suggestive as well, just to make things more confusing. Okay? So if you have a positive Barlow there, but a negative Orlani, does that even make sense to you right now? It doesn't, right? And that's what I was just getting at. Okay? But if it's just a strictly positive Barlow for now, until you go home and watch the videos and think about it a little bit, okay? You can handle it at PCN level. When they say PCN, do you think they mean pediatrician? Probably. Okay, but depending on where you are, you may be the pediatrician today. Look at that face. Who wouldn't want to take your kid to him? Okay. All right. So you're also going to refer all asymmetric hip abduction. So Orlani Barlow is one thing, right? Those are specific tests. That's not the same thing as just doing abduction, adduction. You're actually applying forces, correct? But then when you're just doing range of motion, then you have limited ability to take the legs and put them into that frog-like position outwards. I'm not going to demonstrate it. Put your cameras away. Okay? But if you have asymmetric hip adduction, you're also going to refer them. Okay? That's the conclusion. Any questions? That last one, at some point, please watch the video before we talk next time. Okay? Because they're not going to explain it at once. Good luck with your test. I'll see you guys tomorrow.